support rounds. My name is Einat, and I'm the clinical manager for the Toronto Central Behavior Support for Seniors program based at the Baker's Health Sciences. Before we start, although we are meeting virtually, we acknowledge that Baker's and our related Toronto Central and Behavior Support programs operate on the traditional territories of many Indigenous nations, which have cared for the land for thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize that the current treaty holders, the Mississaugas of the Credit First Nations, this land remains home to many diverse First Nation, Inuit and Métis people, and is subject to the dish with one spoon, wampum, an agreement of to peacefully share to peacefully care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located at and to consider your relationship to the land and to the people who are the traditional keepers of the land. For those of you that are new to rounds, behavior rounds occur monthly on the third Thursday of the month from 2 to 3 p.m., bringing together stakeholders from different sectors to share knowledge, tools, and best practices and promote integration across the sectors to benefit our mutual client and caregivers. The round reach up to 50 different sites across the province and are sponsored by the Behavior Support for Seniors program at Toronto Central LIN and the Center for Learning, Research and Innovation, CLRI, bath based at Baker's. The success of these rounds is truly a system effort of multiple knowledge brokers from around the province. And I continue to invite sites to participate in presented rounds and to share from their great work and innovations. Before we move on to our topic today, I want to remind people that these sessions are recorded and also live streamed to YouTube to benefit those that cannot access Zoom. Those are on YouTube. If you want to use the chat to comment or ask questions, you need to be signed into Google to be able to do that. And our moderator will copy them from that chat into the Zoom chat so we can respond to them. Also, please keep in mind 30 seconds lag between broadcasting from Zoom to YouTube. We will archive a recording of our rounds for later viewing on the CLRI and BSO websites, and we will post those links shortly on the chat. And we will also be sharing the slide deck, but minus the videos that will be presented here. I also wanted to highlight that starting this month, we will be offering a certificate of completion, or more so of a certificate of participation for those that are participating in our rounds and have completed our SurveyMonkey to provide feedback for rounds. Please note that at the end of rounds, there will be a poll of 2 quick questions that we will ask you to fill in as feedback. But on top of that, we do have a more in-depth but very brief survey that we will send and also post a link through SurveyMonkey. Should you be interested to also receive a certificate, you will be required to fill in the survey first, and then you will be able to fill in the certificate. And please make sure to indicate your name accurately when you fill in the survey so that it will be accurately represented on the certificate. Your name will not be linked with your survey responses. So with all of that miscellaneous, I'm happy to finally get to the topic today, which is about pharmacological management of responsive behaviors. Our speaker today is Dr. Morris Freedman, who is the head of neurology and medical director of cognition and behavior at Baker's Health Sciences. He is a professor, Division of Neurology, Department of Medicine at the University of Toronto, and a scientist at the Rotman Research Institute of Baker's Center. Dr. Freedman is carrying out research aimed at improving our understanding of the cognitive mechanisms underlying dementia due to Alzheimer's disease and frontotemporal dementia. His research also includes the development of cognitive assessment procedures in dementia, such as the Toronto Cognitive Assessment and the object alternation test. In addition, he has special expertise in distance learning at a global level, using video conferencing, an area in which he has taken a major leadership role in. I would say he is known globally for his work, and I personally have the pleasure and honor of working closely with Dr. Freedman through our new virtual behavioral medicine program through the Seminita Memory Clinic at Baycrest. And he has also been nicknamed by his team as the Dementia Whisperer. So Dr. Freedman, we are honored to have you here. Thank you for your time, and please take it away.
Thank you. Thank you very much, Einat. Okay, so what I'm going to talk about today is the pharmacological approaches to management of responsive behaviors or neuropsychiatric behaviors in dementia. Let me just, it's not advancing, it is now. Okay, so in terms of my disclosures, I have done some consultancy work and been on an advisory board for a pharmaceutical company. And also I will be discussing the use of medications off-label. Okay, so the objectives of this presentation are as follows. So what I'm hoping is that after this talk, participants will be able to discuss the pharmacological approaches to management of neuropsychiatric or responsive symptoms of dementia. Now, I'm going to be focusing on medication approaches. I'll talk a little bit about non-pharmacological approaches, but this talk is about pharmacological approaches. And please understand, this is not to say that non-pharmacological approaches don't work. They do work. And my approach is to have pharmacological approaches and non-pharmacological approaches go hand in hand and work together. It's just that this talk is on the pharmacological side of things. So I actually want to start and show you a video. And this is a video showing the pharmacological benefit of treatment of severe aggression. So what you're going to see is you're going to see a patient in a bed on our inpatient behavior neurology unit, and he was really quite aggressive. And you're going to see him strike out at me several times. And then we treated him with a medication. It was carbamazepine. And after a very short time, his aggression subsided. And you'll see me going up to him again. And this time I'll be shaking his hand, and you'll see no aggression. And just so people don't think it was just luck that he didn't strike out, you're going to see me shake his hand again. Okay, so here is the video. Everyone will agree that this man is physically aggressive. So this is after a short time of treatment. An example of pharmacological interventions a pharmacological intervention that was highly successful. And this patient was discharged shortly afterwards. So what are we talking about when we're talking about responsive behaviors? There are a whole host of them. Agitation, aggression, delusions, hallucinations, disinhibition, hyperphagia, apathy, depression, hypersexuality, hoarding. There are lots of neuropsychiatric symptoms that are associated with dementia. And we're going to talk about how we approach these pharmacologically. So what's important to note about the abnormal behaviors in dementia is that they can represent different things. For example, if a person has pain, they may, they really just don't know how to express it. They're really trying to attempt to communicate that they've got pain. They may shout, they may scream. People may be reacting to a stimulus that they feel is stressful, whereas other people might not, such as noise. It may be a learned behavior. Some people scream to get attention. A person could have a general medical illness, such as pneumonia, urinary tract infection. It can be due to side effects of medication, but it can also be due in a setting where behaviors simply emerge for no apparent reason. That doesn't mean there isn't a reason. It means that there's a reason that we don't understand. So if there's obviously a cause, we try to treat the cause. But many times we're left with a patient who is, for example, aggressive, and we really don't know why they're aggressive. There's a reference here at the bottom. Dr. Wolf, who's the psychiatrist on our inpatient unit and psychiatrist in the Sam and Ida Ross Memory Clinic, Dr. Yael Goldberg, who's a neuropsychologist, who's heavily involved in behavioral management, myself. We wrote a review article for Continuum, and this article has much of what I'm going to say. It's a extensive review of pharmacological and non-pharmacological interventions, and Continuum is the continuing education journal that's published by the American Academy of Neurology. So when dealing with behaviors, in terms of successful treatment, one needs critical information. And I can tell you, if you try to treat these behaviors without having this, there's a good chance of failure. So you need to know who's affected by the behaviors. In other words, what are you trying to accomplish? You need to know the triggers, if they exist. You need to know how severe these behaviors are. If they're not severe enough, maybe you don't need to treat them. If they are very severe, you do need to treat them, but you may need to treat them more urgently, and that could dictate the dose of medication, the type of medication, and the time of day. Because if you're going to try a medication, certain drugs work better if you give them in close proximity to the time of day that you want to target. And a very key question is, what is the main target symptom? Too often, I see that patients may have a wide variety of abnormal behaviors, and there's an attempt to treat, but it's like you're trying to treat everything. It doesn't work well that way because different symptoms need different types of medication. And this applies also to pharmacological approaches. So before you start, you have to really have the answers to these questions. And at the end of having the answers to these questions, you have to decide, what is it you're targeting? So if somebody is not sleeping and they're highly aggressive, are you going to target the sleep? Are you going to target the aggression? Sometimes you can target both, but you need a very clear idea of what you're focusing on. If you don't have that, then you're already starting off at a disadvantage in terms of being successful. So general principles in choosing medication. First, I think a very important principle is that we start with the smallest dose possible. The other is the maximum dose is generally half of that's used in young adults. So when I have someone who's elderly, who has dementia, or if they have dementia, they're not elderly. The patients who have dementia, their brains are often more sensitive to these drugs. So I target as a maximum dose approximately half of what I would in young adults. And as I mentioned before, a general principle is that we have to be very clear on what behavior we want to target. Then, in terms of choosing medications, and I'm going to show you a list soon of many drugs. I mean, how do you decide? Because many of these drugs supposedly can do the same things in terms of many of the target symptoms. Well, we want to choose a drug that won't worsen through its side effects a problem that's already there. So if somebody has a problem with walking, you don't want to start a drug whose major side effect is poor balance. Same thing, if they've got low blood pressure, you don't want to start a drug that has a high chance of lowering blood pressure. And the same thing with sleepiness, same thing with appetite. And you want to choose a drug whose side effects, even though you don't want side effects, if they're going to occur, they might help as a spin-off. What do I mean by that? Some drugs that may be used to target, let's say, aggression, a side effect may be that they can be sedating. Now, you may not want the sedation in everybody, but if somebody's aggressive and not sleeping, and you have a drug that's good for aggression but is stimulating, or a drug that's good for aggression that can cause sleepiness, you might try to give the drug that's good for aggression and that can cause sleepiness and give it at bedtime. So you really need to know your side effect profile, and you need to know how to use that side effect profile to the patient's advantage. So some more specific examples. You want to avoid, as I mentioned before, drugs that can worsen pre-existing conditions. So if somebody has a gait problem, antipsychotics are commonly used for aggression. But if Parkinsonism is present and there's a gait disorder, you want to try not to use an antipsychotic, even if they can be effective. There are drugs that are activating. For example, the drugs for Alzheimer's disease, the cholinesterase inhibitors, they can be activating. So you don't, even though a person may have significant cognitive impairment and they may never have been on a cholinesterase inhibitor like donepezil, or they are on it, you might want to take them off it, or you certainly don't want to start it because that can cause aggression. There are certain antidepressants that, like we use certain antidepressants for responsive behaviors, and some people are depressed and have responsive behaviors because of that. But you want to avoid an activating antidepressant like bupropion. Another thing that people often forget is mirtazapine, which can help people sleep and might help with aggression and other responsive behaviors. If the doses are higher than 30 milligrams, it can become stimulating, it can become activating. So you really have to know your medications, and you have to know how they work in different doses. Sedating drugs, if somebody's already got apathy, you don't want to pick a drug to treat a responsive behavior that has sedation as a side effect. So you need to balance off the indication for the drug versus the side effect. So, other general principles. If someone is agitated or they're aggressive, let's say they're also depressed. Now, there are certain antidepressants like citalopram that may be good for aggression. So if the person is also has a depressive feature to them, then you might want to choose an antidepressant because you think that may be driving the agitation or the aggression. It may not be driving it, but you might as well treat the depression while you're treating the other behaviors. If it looks like psychosis is part of this, like they've got hallucinations, for example, or delusions, and they're aggressive, then you wouldn't choose an antidepressant. You would choose an antipsychotic. If somebody is agitated and aggressive, in other words, this is all the same type of behavior, agitation, aggression, but they've got compulsions, then you might use a serotonergic drug like citalopram or sertraline. So what I'm driving at here is you can have the same kind of behavior. Let's just use physical aggression as the example. So you can have physical aggression and you can choose 3 different medications based on what else is there. So if they're physically aggressive and depressed, I do one thing. If they're physically aggressive and psychotic, I do another. And if they're physically aggressive and they have obsessions or compulsions, I do a different thing. So that's sort of, again, a general principle. Now, here's this list of medications. Now, this, it's not 100% exhaustive, but this is this is a table that has pretty well the commonly used drugs. So people, physicians who are treating with medications, if they use this as a sort of a guideline, you have the patient in front of you, you go through this list and you say, yes, I'm going to try it. No, I'm not. And you go through each of these drugs and you sort of think which ones are reasonable to use in a certain situation, okay? And which ones are not reasonable. If you do that, you narrow it down to maybe 3 or 4 medications. And then what you have to decide is what you're going to try first, what you're going to try second, what you're going to try third, and so forth. So this is a very important table. So we're speaking in generalities up to now. So let's look at some more specifics. Let's talk about agitation and aggression. So agitation, it's a word that's used a lot. What does it really mean? Well, one definition, and we refer to this in our paper in Continuum, which I do urge you to read, because as I say, it has a lot of good teaching points in there. And as I say, a lot of what I'm saying here, we actually put into that paper. So agitation can be defined as socially inappropriate verbal, vocal, or motor activity that isn't part of a medical condition. Examples are vocalizing, pacing, and restlessness. Aggression can be verbal or physical. And examples are hitting, kicking, pushing, throwing things, spitting, pushing, scratching, grabbing, cursing, screaming, disruptive noises. That I think people are very familiar with. So let's look at specific drugs. For aggression and agitation, especially in the setting of psychosis, we tend to use the atypical antipsychotics, provided there's no reason not to use them. The best evidence, in terms of evidence-based, is for aripiprazole and risperidone, okay? That doesn't mean we don't use the others, because sometimes these drugs fail, but we still want to use an antipsychotic. Let's say there is poor appetite. Olanzapine is an antipsychotic. It's not one of these two, but it can stimulate appetite. So even if these have the best evidence, if I have a patient where I really think we need to improve the appetite and there is no other way to do that, and they are psychotic, and they are aggressive, and they are agitated, I might say, I'm going to use olanzapine. So one has to be flexible in the approach. What I'm telling you here is that we need, whatever we do, we need to know that the best evidence is for aripiprazole and risperidone. In terms of anticonvulsants, the best evidence is for carbamazepine. But we use other drugs, but there's limited evidence. And other drugs like our oxcarbazepine, gabapentin, lamotrigine, topiramate. I had one patient who responded to carbamazepine, but there was adverse effects, and we felt we had to stop it. So here I was, here's a situation where I have a patient, I have a drug that works, but the patient isn't tolerating it. So I have choices. I can try something totally different, or I can say, you know, what other drug is like this one, but doesn't have the same evidence? Well, oxcarbazepine doesn't have the same evidence, but it has similarities to carbamazepine. So what I did with that patient is, instead of going to something totally different, I tried oxcarbazepine, and it worked. So there's an example of the kind of thinking and the kind of approach, because oxcarbazepine is not the drug that one would normally think of to use for agitated aggressive behavior. Valproic acid is something that we did use. It's a drug that we did use a lot previously, but the evidence just isn't there, and it is no longer recommended for agitation and aggression in dementia. Let's talk about drugs with a positive spin-off from side effects for treatment of agitation and aggression. So memantine, which is a drug that's approved for Alzheimer's disease, has as a possible side effect a calming effect. That can be good or bad, the calming effect, depending upon what it is. The person is very apathetic and overly calm. You don't want a drug that has a calming effect. But if they're agitated, they're aggressive, they're hitting, you do want a calming effect. So if the usual things fail, and I have a patient who has something other than Alzheimer's disease, where memantine is not approved for, I will use memantine off-label to see if it might help the behavior and might have a calming effect. Off-label means use of an approved drug for a non-approved indication. Okay, so and we do treat off-label. If you treat off-label, then the patient or the substitute decision maker need to know that you're using a drug off-label. Drugs also like trazodone. Trazodone may be used for agitation and aggression. One of the spin-offs of trazodone is that it can cause sedation. So we might choose that one because we want it to help sleep. So there's really a lot. The message I'm trying to give you is it's not so simple. It's not that person has this symptom, we're going to use that drug. You have to look at the whole picture. You have to look at what you're trying to target and what you're trying to accomplish. Now, sleep problems can actually underlie the disruptive behaviors. And families will tell you, and I think it's extremely important to listen to families, because a lot of the information to decide what to do comes in the history. And often people are told, the healthcare professionals act, if they listen, they're actually told what the issue is. And listening to that helps choose the treatment. So the history is extremely important. So if we want to treat sleep, then there are certain drugs that can do that, and at the same time have a spin-off for aggressive behaviors. Trazodone is one, mirtazapine, but remember in lower doses. Quetiapine can help with sleep. Olanzapine can help with sleep. It can also help with appetite. Gabapentin, which is used for many different things, can help with agitation, aggression, and help with sleep. And zopiclone can help with sleep. And in the elderly with zopiclone, the advice now is to use no more than 5 milligrams at bedtime. Now, for resistive behavior, if psychotic features are the driving factor, I repeat, we would use antipsychotics. If depression and anxiety are the driving factors, we would use antidepressants or anti-anxiety medications. Now, sometimes we need a PRN, which is an as-needed drug, before feeding or care. Now, you would like to have the option of having one that can be given subcutaneously or intramuscularly. Now, lorazepam can be given, olanzapine can be given by injection. Trazodone can't, but it's worth trying an oral. All of these 3 drugs can be given orally. So it's worth trying orally first, but sometimes it doesn't work. So if we're talking about an IM injection, we're talking about lorazepam or olanzapine. So those 3, lorazepam, trazodone, olanzapine, can be given orally, lorazepam, olanzapine intramuscularly. Okay, loxapine can be given intramuscularly too. Resistive behavior during feeding is another issue. Now, the first thing there, when someone is not wanting to eat, is you have to see if they've got a poor appetite due to medications. And the two commonly used drugs that can cause poor appetite are the cholinesterase inhibitors. Those are the drugs for Alzheimer's disease, donepezil, galantamine, rivastigmine, and the SSRIs. And those are drugs like citalopram, sertraline. So if someone is on those drugs, then one might want to consider stopping them. You don't have to stop them, but it's something to consider. Also, this goes back to the choice of medication. If we want to treat the resistive behavior without specific, and we're not sure why the appetite is poor, drugs like olanzapine, if there's psychosis, or mirtazapine, if there's anxiety or depression, are worth considering, because these drugs, olanzapine can improve appetite, and mirtazapine can do the same thing. Now, perseverative and repetitive behaviors. Now, this is something that it's very difficult to treat. The question is why a person has repetitive behaviors, why they have perseverative behaviors. And sometimes it's due to obsessive compulsive features. And if you think that's what's happening, then it's worth trying an SSRI like citalopram or sertraline, because SSRIs can help with obsessive compulsive behavior. And what this is, what I'm showing you is an example of how you can look at a behavior and say, well, this person never had OCD, obsessive compulsive disorder. But if nothing is working, you might say, well, maybe at this point in time in their dementia, they are developing obsessive compulsive behavior. Framing it that way is what sets it up for a rationale to try the SSRIs. And they do work in some of these cases. Now, sometimes the drug, I've got clomipramine listed there. Clomipramine is an old drug. I rarely prescribe that. But we've had some patients who they've got repetitive behavior. They look like it could be compulsive behavior. The SSRIs may not have worked. And I remember this was on our inpatient unit. I said, well, let's stick with this idea of the obsessions and compulsive behavior. Nothing has worked so far. Let's try clomipramine. And it worked. We had a second case where nothing seemed to work. We tried it and it worked. We had a third case and it worked. We actually wrote this up for publication, and it was accepted for publication using clomipramine for obsessive compulsive behavior or type behavior in dementia. So what we must, don't forget the old drugs. The old drugs sometimes work, but I don't use them first. I use them if all else fails. Doxepin is another old drug. And we actually published a paper back in 1992. It was from Aggres, where we had, and in those days, people were using doxepin. It's a tricyclic antidepressant. And so what happened was we found that patients who were noisy, but were less noisy when someone was with them, tended to respond to doxepin. And we published this. And so now I have some patients who don't respond to anything, and I try doxepin. People don't like doxepin because, or at least physicians don't like doxepin because it's anticholinergic. But sometimes the benefits outweigh the risks. Disinhibition and hypersexuality are another difficult to treat problem. One thing is that dopaminergic drugs can cause this. Benzodiazepines can cause disinhibition, and that can manifest as hypersexuality. So what we do is we try drugs like trazodone. Paroxetine is an SSRI that's quite anticholinergic, but there is some evidence that it might help with hypersexuality. Clomipramine might help, citalopram, cyproterone might help, leuprolide might help, quetiapine. There's a series of drugs. But the first thing to think about is to reduce drugs that might be causing this problem. Hyperoral behavior, where people eat anything in sight and overeat. That's a problem you see in frontotemporal dementia. It can be quite severe. It can cause problems where patients may go and take food from other patients. Other patients may get upset. They may strike out. You may get aggression, and then it just escalates. The drugs that might olanzapine, for example, might actually produce this hyperoral behavior. Clozapine, topiramate might do that. Now, the treatment of that, we often try SSRIs, and the SSRI that I often try first is a drug that we often don't like to use in the elderly. It's fluoxetine. This drug can be stimulating, and it has a long half-life. But fluoxetine can reduce appetite, and it often works for hyperoral behavior. Clomipramine might work, on the idea that it might be a compulsive behavior. Now, hallucinations and delusions, when they're there, in addition to trying to treat them, we want to make sure that the person isn't on any drugs that might cause psychosis. For example, in Parkinson's disease, patients are often on levodopa carbidopa, and those drugs can cause psychosis. So one might want to think about reducing them, but you can't always reduce them because the Parkinson's may get too bad. So the treatment there would be antipsychotics, but also the cholinesterase inhibitors, drugs that are used for Alzheimer's disease. Those drugs can also have an antipsychotic effect. Now, they can also cause aggression, which is a bit of a problem, but it's important to know that they can also reduce hallucinations and delusions. Frequency of adverse reactions. Important to know what the side effects are. Now, there's a handbook, a clinical handbook of psychotropic drugs. And Anne Kirstein, our pharmacist on 4 West, introduced me to this book. It's great because it has tables of pretty well any drug that you can think of. It gives you frequencies of side effects. You can compare one to the other. It's an extremely useful reference. So I've got it here written there, and it's a great source to use. Non-pharmacological approaches. I'm not going to talk. This talk is not about that, but I want to say a little bit about it, just so that we have a little bit of balance here. So non-pharmacological approaches for aggression. What you want to do is you want to avoid environmental triggers. Now, for some people, wandering into an open door is a trigger, and they'll wander into somebody else's room. So sometimes just putting a stop sign on a door might help. Another is you can take a sort of drape or something that's about two feet high, and use Velcro, and you sort of put it over the doorway. That sometimes works. I mean, often the other patient would just ignore the stop sign and just take the thing off, even though it's there. White noise, calming music might help with some people. If you have an exit door where people go, you can paint it so it doesn't look like an exit, make it look like a bookshelf. So there's things you can do to treat behaviors non-pharmacologically. In terms of resistive behavior, like people who are resistant when you're trying to dress them, sometimes it may be because they have no idea what you're trying to do. And so trying to get them to understand And if they don't understand verbally, you might want to try visual cues. People who really don't like showering, first of all, you have to make sure that the shower is comfortable. I mean, I have seen situations where people were sort of, taken to a shower very abruptly. No one checks the temperature of the water. And of course, you're going to have a problem. And even if the next time it's good, they're going to remember the first time and they're going to be resistant. But if there's no other factors like that, you could try and reduce the frequency. If people are resistant to shaving, you don't have to shave every day. Bathing, you can try a sponge bath. So there are things that you can do to try and work around the problem. Feeding, if someone is not eating, I mean, you got to check for medical problems, make sure they don't have swallowing problems, make sure they're not choking. You may want to try and reduce the amount of food per meal. But if you do that, you got to increase the number of meals because you want to give them the same amount of food. Changing the food to what patients like. We've seen that, where patients won't eat because they don't like, that's not the food they're used to. So we need to be open to the idea of letting families bring in food and changing not be so rigid about the fixed menu in a long-term care facility, for example. For perseverative and repetitive behaviors such as picking the skin, you got to make sure there isn't something physical going on, like a dermatitis or something that's creating a physical problem. Hyperoral behavior. Remove objects that can cause harm. We had one patient, Mindy Halper, who's our nurse clinician in the memory clinic. I remember vividly, we had a plant that was on her desk, or she had a plant that was on her desk, and there was a patient who was hyperoral. He just grabbed the plant and ate it. You got to make sure you don't have, some flowers are poisonous. This one wasn't, but you got to make sure you don't have poisonous flowers around. So be careful. You don't let people just bring flowers in because hyperoral patients can eat them. You might have to remove the patient from a common dining room. So these are all non-pharmacological approaches. Okay, I want to end this, so we have time for questions, but I want to give you a case example or two, maybe just give you one. So there's a 58-year-old woman with behavioral variant frontotemporal dementia. She was in acute care. We saw her in our virtual behavioral medicine program, our VBM program. And she was successfully treated through that program while in acute care. She would grab food from other patients' food trays. At meal time, she would charge towards the wagon that had the food. She'd push anybody who was in her way would just get pushed aside or mowed down. So she was on clozapine, sertraline, trazodone, Zopiclone. So the question is, what would you try? Okay, so you remember I spoke about this. So what we did is we put her on fluoxetine, and it resulted in significant improvement. Okay. One more case. A 75-year-old man with Alzheimer's disease, acute care, severe aggression, hitting, biting, kicking, on donepezil and risperidone. Question is what you would do. Well, you would do something different than the person was already on. This slide was set up for an interactive session. We're not having an interactive session with 300 people where I'm going to start asking what you would do. So let's just go through it. We switched to olanzapine, didn't work. Put on carbamazepine, helped behavior, but gait got unsteady and appetite was poor. We switched to gabapentin, helped for a short time. What would you do? This is the one that was put on oxcarbazepine and got significantly better. Okay, it's now 1:45. So what I'm going to do is I'm going to stop screen share. What I've done is, just to summarize, I've reviewed a sort of general principles and an approach to pharmacological interventions, tried to give you general principles, tried to give some actual specific suggestions for how one might deal with specific situations. It's actually, it's quite complicated because there's a fair number of medications to use. And one really has to determine the benefits, the risks in deciding which drug to use. And you'll get a lot of differences in choices. That doesn't mean that one choice is right and wrong. There are clearly different approaches. So there are many right approaches. What I try to do is to give you a way to reason through this and to come to, for those who prescribe medications, to come to a conclusion as to, and come to a strategy and a plan as how to approach this. So I'm going to stop, and I'm happy to answer questions.
Thank you so much, Dr. Freedman. This has been such, such a complex topic, yet you were able to communicate it so clearly to the audience. I have the first question for you, if you wouldn't mind repeating the outcome of the case number 1 that you've presented. Specifically, what was the outcome of the case?
Oh, she stopped being so aggressive with the food to the point where it was actually manageable. I mean, she still wanted food, but she wasn't mowing people down, pushing people aside. As soon as the trays come, she would start banging on the door. They would try to keep her away from the other group. All of that behavior subsided to a point where it was really quite manageable.
Thank you. So I'm seeing quite a few questions coming in. So there's a question if there is any pharmacological intervention for hoarding.
Yes. We have a patient right now on our unit, on our inpatient unit, that she major league hoarding. She now is perfectly manageable. She is waiting for long-term care. Our big problem there is not stopping her hoarding. Our big problem there is finding a bed for her in long-term care, which is a different issue. And we sort of conceptualized the hoarding as a compulsion. So what we did is we tried treatments for compulsive behavior. And she was put on clomipramine. She's also on an antipsychotic, I believe, so it's combination drugs. But the clomipramine worked. And she's manageable.
Thank you. Another question from Jamil. How long would you trial a medication to deem it effective or ineffective?
Okay, it's a good question. What we do to try, the way I approach this, once I pick a medication, I know what the starting dose is, I know what the maximum dose is. So if I start the drug and I start to increase it, and if I see, if there are side effects, we stop it. Okay, so that is a reason to not go further. If there are no side effects, I keep increasing. I don't always go straight to the maximum because experience tells me, let's say a drug like risperidone, where the maximum in a younger person would be 6 milligrams, the maximum in a person with dementia would be 3, in my view. So if I get to 1.5 or 2 milligrams and see absolutely nothing, instead of taking the time and going to the full 3, which I might do, I might say, you know what, this person is really quite aggressive. I think it's very unlikely that if I get to the 3, that it's going to work. I might shift at that point. So the limits are the maximum dose, but I use judgment where to stop before I get to the maximum dose. If I really think it's not going to work, and I don't feel we have the time to wait. But the risk there is you got to be careful not to stop too soon. So I won't start, if I start in a low dose and there's nothing, I won't say I'm going to stop. I'll go to a higher dose. In other words, I'll get to a reasonable dose before I will decide that it's not working.
Okay, so the next question, thank you, Dr. Freedman. The next question is about any pharmacological and non-pharmacological recommendations for dementia with Lewy bodies for someone that is presenting with somnolence for 3 to 4 days, and awake and alert for 1 to 2 days.
Okay, well, people with dementia with Lewy bodies can fluctuate, first of all. So they can be alert at one point and somnolent at another point. They can be very good cognitively and at one point and not good cognitively at another point, okay? So the first thing is cholinesterase inhibitors, the drugs that are approved for Alzheimer's disease, may help in dementia with Lewy bodies. So often that's what I will try. And if sleepiness is an issue, the cholinesterase inhibitors are alerting, they're stimulating, okay? Now there, you see, they can be given daytime and nighttime, but what I would do there is give it in the morning, not at the bedtime. Okay, so there's the choice of the drug and there's the timing of the drug. Now, what you wouldn't do, patients with dementia with Lewy bodies can have something called neuroleptic sensitivity, where they can become overly sensitive to the Parkinsonian side effects of antipsychotics. And these patients can become stiff as a board with a low dose. Now, the scenario that you described where they're alert and sleepy, I wouldn't want to use an antipsychotic anyway. But if they were, I just want to throw that in when you say what I would and wouldn't do. I'm very cautious with dementia with Lewy bodies in using antipsychotic medications. That kind of patient, I would start, the one that was, the example was, it was given, I would start with a cholinesterase inhibitor.
Many more questions. We're probably not going to get through all of them, but a few more. Any short-term medication to be used for aggression?
Well, all of the medications that I'm talking about can be used short-term. They're not, in fact, it's important to reevaluate. And if somebody's doing well after a certain period, to take them off. The big problem is that if I have a patient, when I say doing well, I don't mean take them off a week afterwards. I'm talking about a few months. So if I have a patient who is very aggressive and I put them on an antipsychotic and 6 months later, they're doing very well. And, you know, I say, well, we shouldn't keep the person on for years. The families are often very resistant to stopping it. They feel things are so good, they don't want to risk. Because one of the risks of stopping these drugs is that the aggression and agitation will come back. And so so I end up actually keeping people on longer than I might want to, because families don't really want to risk it.
It's always a kind of a fine balance and a trade-off.
Yeah, they say that if there's no real side effects, they say, look, the person really doesn't have any side effects. Now, sure, there are long-term side effects and problems like that, but families are really worried about that aggression coming back.
Mm-hmm. We see that also in non-behavioral approaches when you're trying to kind of unwind the pattern of communication that has been there for a while, and convince staff to approach it in a different way. So I definitely can relate from that perspective to what you're saying. Dr. Freedman, another question is, how do you approach some of these behaviors in the context where there is pain and or addiction? Where is the fine line between compulsive behavior and addiction?
Okay, well, there's several questions in there. Pain,
yes.
Pain is probably an under-recognized cause of responsive behaviors. And we are doing our best to focus on that, both in, especially this comes up now on the inpatient unit. And there are several patients that we are treating with pain medications like hydromorphone, who have agitated aggressive behaviors. And it does seem to help. Now, if you're worried about, I'm not an addiction expert, so that I'm not sure I'm the best person to answer that kind of question. But in terms of pain, it needs to be recognized as a potential cause.
Absolutely. Sherry Williams, you've asked to ask your question in person. Would you like to unmute yourself very quickly and ask your question?
Hi, actually, I'm with Sherry Williams. My name is Sayed, and I work in Rouge Valley Extended Care. My question is, one of my residents, she is having psychosis and resistive to care and shower, self-talk. She is already on risperidone, low dose, 0.125 BID, and she has PR and trazodone. So now they added lorazepam before care, but I don't see it's very effective. My thought was if we can increase risperidone or trazodone rather than adding lorazepam. What is your thought about it?
Okay, let me be clear on this first of all myself. How much risperidone is she on?
0.125, I think. I'm not sure. Yeah, 125 and 0.25
Okay.
HS.
All right.
In the morning, she is 125, and at night, 0.25 HS.
Okay. Now, what behavior is she showing?
She is very aggressive. When we provide her care, she completely don't follow, and she get very aggressive. She self-talking, and she don't let us to touch her at all.
Okay, so the risperidone is in a relatively low dose. So
Right.
the answer is yes, one can go with the doses you mentioned to me, you can go up higher. The idea there would be to get a level, a dose that would carry her through so that she wouldn't need any kind of intervention prior to care. But you at the same time, while you're increasing the risperidone, one might give something like lorazepam prior to care to do the care at that particular point, with the idea that if the risperidone or if the risperidone doesn't work once you're in high enough doses, whatever else you try might end up working for all the care periods, and you won't need the PRN. You're saying lorazepam doesn't work as a PRN?
No, it's not really working.
How much is she getting?
0.5, 3 times a day before care.
So each time she's getting 0.5.
Yes.
Milligrams. You have to understand, I can't give you specific, I'm speaking generalities here. I've never seen this patient, okay? So please don't take this as advice don't take this as a consultation. Take it as general comments.
Yes.
One can go higher on the lorazepam. It depends on how severe things are.
Okay.
We are reaching, I see hands up and lots of questions in the chat. Maybe we'll finalize with one question. I don't know if Dr. Freedman, you'll be interested maybe to look at the remaining questions after the session and maybe provide some kind of response, and we can get back to participants based on your abilities and time. But Salma, just in case, let's just copy them off the chat so we can capture them. Last question would be, what is the best psychotropic drug for a resident with Parkinsonism, with dementia, who is very physically and verbally aggressive? He's already on Seroquel, 25 milligram bead, and valproic acid, no PRN for agitation. Okay, so they got Parkinson's and aggression. Okay, and first of all, sorry? Yeah. Parkinson with dementia, yes. Parkinson's, dementia, and aggression. The first thing is, I would try to treat this without an antipsychotic, okay? So I would try drugs, for example, gabapentin is a possibility. Trazodone is a possibility. I don't know if the person has been on these medications, but there are other drugs. If you look at that, there are other drugs that one can try. Let's say we're at the point where nothing works and we need an antipsychotic. Okay, quetiapine, I can't remember the dose that you said. How much was it? 25 milligram. Okay, quetiapine is the one that people most commonly use because it's felt to have less extrapyramidal side effects, but this is all dose related too. 25 milligrams is a very low dose, so one could go higher. But in terms of the antipsychotic of choice,
it would be quetiapine. If the extrapyramidal effects were just too great and one really needed an antipsychotic, one would go to clozapine. Now, clozapine requires blood tests to monitor the blood, the white blood cell count and platelet count. It would need that every week initially, and then every 2 weeks. But that is the drug that we use if we need an antipsychotic and we can't use quetiapine.
Thank you. Dr. Freedman, I want to share with you, there is a lot of warm comments on the chat, lots of interest in your talk and lots of appreciation for the presentation with lots of warm responses. We are at time. We will copy some of those questions. I know some people ask also about application to a CAS unit. If you would like to also attach your email, I'm happy to get back to you specifically on that question to your email. And if you post your email on the chat to me. But apart from that, I really want to thank Dr. Freedman for this great presentation and for being with us today. And I want to thank to all of you for participating and our moderators in the back end that made sure that everything works smoothly. Thank you very much, everyone, and have a wonderful day.
Thank you.